Good evening, everyone. Welcome to our webinar. I'm Fatima Al-Ghadib. I'm Chief of Organizational Excellence in Al Musa Specialist Hospital. You will be hearing a presentation from Dr. Natalie Pluton. She will be speaking to us on a very interesting topic, how healthcare professionals can enable patients to be proactive partners in their care. Dr. Natalie is a senior lecturer in nursing and internationally the Faculty of Healthcare and Society at the University of Salford, UK. Also, Dr. Natalie is an executive coach for senior leaders in the UK National Health Services, NHS, and an associate consultant for an international dementia care organization. Welcome, Dr. Natalie. We will now be moving along to our session. Kindly welcome Dr. Natalie to deliver this presentation on this very interesting matter. Just one thing, you have a box of question and answer. There is an icon in the below. If you have any questions, kindly write them there. We will be addressing them most likely at the end of the session. And if there is anything relevant, we will address the question directly to Dr. Natalie. Welcome, Dr. Natalie.
Thank you so much. Thank you for the invitation to connect with the Saudi Patient Safety Centre and all of the attendees at this lecture this evening. So I have a passion for patient engagement, and I'm also really excited to be connected with Saudi Arabia and the amazing work that's going on in Saudi Arabia as part of Vision 2030. And all I'm reflecting on here in my lecture is my experience in the UK, sometimes when we've got it right and sometimes when we haven't got it right. So I'm certainly not here to say that the story I'll be telling this evening is about how we always get it right in the UK. It's a more mixed story about how sometimes we get it right and how we can improve how we partner with patients and how we enable patients to be proactive partners in their healthcare. So the objectives this evening, just to focus your thoughts after your day at work and as you're still learning as we go on into the evening. So the objectives for our time together this evening are that we'll be thinking together about how we can identify opportunities during the patient journey where you and we and healthcare professionals all over the world can support, empower, equip and enable patients to be proactive partners in care decisions. And we'll also be thinking about how we can identify the potential positive outcomes of involving patients as partners in communication about their care and care decisions. So I'll be coming back to some of these words, and maybe some of your questions will be about these words. A couple of other words I'll be using today, just to let you know where I'm going, are thinking about advocacy, about our role as the advocate for the patient, and how that role of us being the advocate of the patient can enable the patient to be proactive in their decision making. And then the other word that comes along with that is autonomy, about patients' autonomy, how as the advocate we support their autonomy so they are then proactively involved in their care decisions. During our time together, I'd like you to be doing some reflection, some critical reflection and self-assessing how at the moment you as an individual and also your organisation and your department, so how you, your department and organisation support, empower, equip and enable patients to be proactive partners in their care decisions. Some of that I'll be asking you to share anonymously in a poll, and other aspects of the reflection, just make some comments, give yourself some scores, think about how you would like to improve individually, departmentally and organisationally in terms of enhancing patients being proactive partners in their care decisions. And then towards the end, just briefly, a little consideration on how to enhance your evaluation at a departmental and organisational level to enhance the extent to which patients are supported, empowered, equipped and enabled to be proactive partners in their care. Just a couple of statements just to see if we're on the same lines, and feel free to disagree with me in the chat box. Some critical discussion and debate is always good for us all to learn. So just a couple of statements, and maybe think about if you agree, disagree, or unsure, have questions about either of these statements. So the first statement, how healthcare professionals engage with patients has a significant impact on the patient's experience of care. So just have a think about that. Do you agree with it? Disagree? Have some thoughts on that statement? And the second statement is, when healthcare professionals ensure that patients are proactive partners in care, the outcomes are care decisions that are life effective for the patient. And I probably strongly refute any debate on that, just because of the literature. The global literature is giving us that as the answer to research questions on what difference does it make to patients, and it's life effective for patients. It's also cost effective for healthcare organisations, and having patient-centred care, engaged patients, actually improves the quality of work experience for healthcare professionals, so that there are benefits all round from this approach. So the way we're going to work through this session this evening is it's a case study. Ideally, we'd be in the same country and we'd all be in a big classroom, and we could engage in discussion about this case study, but it's going to be a bit more creative and work globally and work online this evening. So whilst I share this case study with you that comes in 3 parts, I'd like you to consider your professional code of conduct. And when I describe the care that a patient received in the UK this year, anonymously, so no mention of the organisation or the patient or the patient's condition, as I go through this 3-part case study, I'd like you to reflect on your professional code of conduct and what would you have done in that situation with that patient to make sure that they were proactively involved in their care decisions. So the case study, it starts with an emergency situation and a life-threatening condition, and the patient's alert throughout. The patient's then transferred to a ward, the care changes, and then the patient's discharged home, comes back in because the discharge was flawed. And then the patient's journey concludes with the patient receiving care for a minor procedure in a different department in the same organisation. So that's where we're going. Just thought I'd put you a little map out there so you know where we're going with this. So throughout this case study, I'd like you to be thinking about your code of conduct. How would you have engaged with this patient in this situation, in your professional role, with your professional commitment to enhancing a proactivity and involvement with and from the patient? And I'd also like you to think about the vision and mission statement of your organisation, and what would the patient's care have been like in your organisation for this anonymous condition. And it could be, it could be a male, a female, old, young. So that's why I'm being purposefully generic when I mention the patient's condition, but just think about a similar patient who maybe you've heard about or cared for in your organisation. How do the vision and mission statements of your organisation really, realistically, in day-to-day life, impact on the patient's experience of receiving care that's outstanding, but also being an equal, proactive partner in the decisions that are made about their treatment, and thereby decisions that impact on their life once they're maybe not meeting with you on a regular basis because they're now at home, or you care in the community and you only see them on a infrequent basis. So just be getting yourself into this mindset of a framework to evaluate the care that I describe. So this case study is very contemporary. It's from 2022. and reflect how you would have acted as the patient's advocate to support their autonomy and thereby enable them to be a proactive partner in decisions about their care. So advocacy and autonomy, I argue, are two really important aspects of enabling patients to be proactive partners in their care. So thinking about the word advocacy, seeing as I keep saying it's important, thinking about where this word comes from. In some European countries, I know in France, lawyers are referred to as advocates. So the word has its root in the legal profession, and originally it's from a Latin word meaning advocatus, meaning one summoned or one called in to plead the cause of another. And in healthcare, we're taking this a little bit differently because we're thinking, yes, we're the patient's advocate, and we will be taking that role in our multi-professional interdisciplinary teams. We may be advocating for the patient when they're not there, and we are the one who is serving the patient in the interdisciplinary team with our professional colleagues who are also the patient, the autonomy and self-determination of patients. So it's a slightly legal profession. And if we read the literature on advocacy, we see definitions looking at the defender and promoter of patients' rights, and it's the patient's right to autonomy and self-determination that is really important here if we want a healthcare system where patients expect to be proactive partners in their care. It's all well and good us talking about it, reading about it. If our patients don't know that it's their right and it's our duty to enable this right of proactive involvement in care, if they don't know that we want to share information with them, provide opportunities for them to say how they're feeling and what they need in their situation, it's not going to work. And I know with Vision 2030, enhancing patient empowerment and engagement is repeatedly written through all the different health aspects. So we're all learning, and as I said at the beginning, I'm certainly not saying that as I sit here in Salford, in Greater Manchester in the UK, I'm certainly not saying we've got it all right. I'm certainly saying it's equally important in Salford, in Saudi Arabia, the UK, France, Australia, America. I'm working with Kyrgyzstan at the moment. We're working with their Ministry of Health, and they're working on exactly these same issues. We're all working in the same direction. So reading the literature on what we should be doing as healthcare professionals acting as patient advocates, we should ensure the following. We should ensure that patients have enough information to exercise autonomy. Patients can't be proactive partners in their care if we don't share the information about their care options, their prognosis, their diagnosis, their treatment options. If we don't share that information with them in a way that they can understand and engage in debate and discussion with us, we're not promoting autonomy and we're not enabling proactive patients. And we have the benefit of maybe 3 or 4 years of a degree, 1 or 2 years of a master's, whether we've studied part-time or full-time. We may have had the wonderful opportunity to study for a PhD. So we can take on board this information about health quite quickly. If our patients from the haulage industry, if they're from the construction industry, just looking out of my window, there's lots of construction going on. We have to make sure that all of our patients have enough information to exercise autonomy and be proactive partners in decision making. The literature talks about patients' legal and moral rights being respected at all times in terms of decisions about their life. With patients who have dementia, we have a phrase in the UK, no decision about me without me. And I just think that is so powerful. No decision about me without me. And that is a really useful yardstick, a measuring stick for us to think about, are we supporting patients to be proactively involved in their care decisions? Things get complicated in the real world with healthcare resources in every country in the world. There are pressures on healthcare resources, staff time, staff numbers, levels of staff and their education. So healthcare resources are under pressure in every country. And if we're being advocates for our patients, how are we voicing the aspects where maybe healthcare resources need to be looked at and allocated differently, so to make sure everybody has the right quality and quantity of care? And I like this last statement that I've taken from the paper by Highland, who, when talking about patients, talks about advocacy and our role. We express this by creating an atmosphere that's open and supportive of the individual's patient's decisions concerning care. And again, we need to think about this two ways. It's all well and good as saying, oh yes, we create an atmosphere that's open and supportive for individual patient decision making about their care. What about if we ask the patients, how would they describe the atmosphere in the unit, the department, the ward where they're receiving care? Do they feel every time a professional comes to them, or when a team of professionals come to them, is the atmosphere open and supportive for that individual being involved in decisions about their care? It's challenging. It's challenging to make sure we get this right for all patients at all times. So as I said earlier, there is this link. So advocacy isn't doing on behalf of our patients. Advocacy may be speaking on behalf of our patients when they're not there, but we're speaking on behalf of our patients when we've spent time asking them, getting to know them, getting to understand them, getting to know their values, preferences and beliefs about the care that may be involved at that moment in time. We're also thinking about, with advocacy, that a part of the definition is safeguarding patients' autonomy. I'm just going to move my slide down, or not move my slide down. So this is the case study for today. So that's a little bit of the introduction. This case study is taken from a 6-page formal complaint that was shared with a hospital in the United Kingdom. And it was written by the patient's relative, by their mother, and it describes the care that the adult daughter received. And the report was written as a collaboration between the mother observing the care over a period of 3 or 4 weeks and the daughter's experience of the care. The daughter was too frail and ill to write the formal complaint at the time, although I do know that she has since submitted her version of the formal complaint. It's not all negative. It starts with outstanding care. It then describes problematic care, and then it describes outstanding care again. So there's a bit in the middle where the care meant that the patient wasn't a proactive partner in their care. So that's just to set the scene. And these sections in italics I've taken from the report with permission of the patient. So this is written by the mother. Over a 3-week period, although I think it then went on longer to 4 weeks and subsequently ongoing, but at the time this was describing the first 3 weeks. Over a 3-week period, I accompanied my daughter, who is an adult patient, who's fully competent, cognitively speaking, as she was admitted first of all to an assessment unit and then to the ward connected with the assessment unit. The care from the nurses and the medical staff in the assessment unit was outstanding. They managed the emergency aspects of my daughter's care while simultaneously building a relationship of trust and explaining each step of her care. This was the highest care we could have hoped for. My daughter felt 100% safe and knew that the care being given was focused on her individual needs. So the patient had been admitted with a potentially, well, they didn't know it at the time, but a severe hemorrhage that they subsequently found out was life-threatening. So even in this emergency situation, the nurses and the doctors made sure that they created that open and supportive environment that Highland talks about in their paper about us being advocates, and then creating this open and supportive atmosphere so the patient can be self-determining of their care and is fully involved in this emergency situation. So what the nurses and doctors did, it's quite simple, introduce themselves by name and by role. The nurses and the doctors asked assessment questions throughout the initial emergency situation to enable patient-centered care. So it wasn't just emergency care to save the situation, save the patient's life. It was to, even in that situation, enable patient-centered care. The mother writes that the shared information enabled my daughter to be included in the decisions that were being made about her care. So the mother who was observing could see that the patient was central and was fully consenting, fully informed, very proactive, even in this emergency situation. Information was clearly provided for each care intervention. So my daughter was able to consent to each action, and she knew how and when each step of the care was going to be provided. So this is what the formal complaint starts with, the opposite of a complaint, highlighting outstanding, excellent care, where even in an emergency, the patient is centre and is proactive and is supported by the interdisciplinary team. The report goes on to say, even in this situation, every opportunity was provided for my daughter to ask questions about the care being provided. Throughout her care in the assessment unit, from stepping onto the unit to leaving, the nursing and medical staff checked how my daughter was feeling physically, psychologically, and emotionally. So it's like textbook perfect. The care provided was an outstanding example of prioritising people. The patient was prioritised, practising effectively, preserving safety, appropriate with the patient safety centre, and promoting professionalism and trust, and was delivered by the most inspirational of nurses and doctors. So in the report, the mother of the patient writes, if we were to rate this patient's care out of 10, we would rate it 1,000 out of 10. The report goes on to say, these were outstanding healthcare professionals whose care, knowledge, humanity, professionalism, and compassionate communication we will always be grateful for. So I'd like you to be thinking, as I said at the beginning, about your professional code of conduct, the vision statement in your organisation, the mission statement. And I'm going to ask you to reflect on the last 3 patients you cared for in your department, or generally think about the care of your department if you've got a more managerial role. And I want you to rate yourself, and this isn't for sharing, this is just for you to do a self-assessment out of 7. So you might think 7, why not 10? So I've said 7 because if we say 10, which I will ask as a question later out of 10, we often go, oh, well, 5 maybe, but I don't want any half numbers. So you can't say 3.5. So there's no going down the middle. That's why I've chosen 7. So thinking about the last 3 patients you cared for, or if you're a more managerial role in your department, how would you appraise, evaluate the care provided in terms of advocacy and promotion of patients' autonomy that promotes proactive involvement of patients in care decisions? But the words I've taken here are from a paper on advocacy. So the word apprising, which I have to confess I hardly ever use, but that's the word in the paper. So apprising, meaning providing information to the patient about their diagnosis, their treatment, their prognosis, the suggestion of alternative healthcares, and providing information about their discharge programme. So give yourself a score out of 7, 7 being as good as you could be in this providing of information, this apprising, 0 being you didn't do very well at all. So that's your first one, for your eyes only. And the second aspect of this paper on advocacy I'd like you to assess yourself on is the last 3 patients or this day in your department. How did you or you and your team get on with valuing patients as a support of their autonomy through your advocacy? How good were you at maintaining patient self-determination, enabling patients to make decisions freely, maintaining individualization and humanity? How well did you or you and your colleagues do at maintaining patients' privacy? And how well did you do at acting in line with the patient's values, culture, beliefs, and preferences? Because this all is part of this open and supportive atmosphere that means patients, once they've got the information, they then have this valuing atmosphere, they can then become proactively involved in the decision making. We've been trained for it for all our professional careers. Patients probably haven't, and this is why we just need to revisit some of these principles and make sure that both us individually and our colleagues, our teams, our departments, our organizations are really aspiring to enable, equip and empower patients to be proactively involved in decision making. That was another score out of 7 for you. And then the third and final aspect for you is mediating. So either you or your department, how would you rate yourself out of 7 for liaising between patients, family and healthcare professionals? How do you rate yourself for being the patient's voice and communicating patient preference and cultural values to members of the healthcare team when the patient isn't there, and maybe when their family representative who they've allocated to speak on their behalf, when they're not there? How are you doing in liaising with the patient and the family so that you can then be their voice and communicate when they're not there? So again, another score out of 7. And where you're not scoring yourself as 7, and I think we're always trying to improve, and the more we improve, we find out there's more to learn, and so we're always looking at ways of improving. So I want those scores are just for you to think about, but if there are some points that came to mind, you think actually my score could have been better there with the last 3 patients I cared for. I was short of time. I knew I needed to get to a different department. I know I fast forwarded the process, and I know the patient wasn't as proactively involved as they could have been. It's about that honest evaluation and thinking, well, next time I'm in that situation, what will I do? How can we have a plan in mind so that we don't miss those opportunities going forward? So this is one for you to share. This is a poll question, maybe just reflecting on some of the questions you've just reflected on. And this is anonymous, as the case study is anonymous, so we won't know who's given which answers, and just to get a bit of a feel for where you're at. So if 10 is the maximum score for your department, in terms of ensuring that all patients are truly proactive partners in their care, how many points does your score need to improve by? So first of all, rate yourself out of 10, and then work out how many you need to add to improve. And I think that's a really good question to ask ourselves. What does the best look like? What does outstanding look like? Where am I now? And when we know how far we need to go, then the next step, if we were in a workshop and we were together a bit longer, we would start to think about how can we take action individually? How can we take action in our team? How can we take action across our interprofessional teams, across departments, and as whole organisations? So thank you for sharing there. So some may, have well been working on this for some time and already making progress. So I would imagine those would be the organisations and individuals that don't have as far to go. The largest group is kind of in the middle, and that shows honest, authentic reflection. And some as saying, you know, we have got quite a way to go, and that is really, all of these are important. We need to acknowledge our success. And that's why I quite like this case study for sharing with you today. It acknowledges the success in the same department where staff get it amazingly right. And then we have, as you're going to find out, staff getting it not so right. And then staff in a different bit of the department getting it amazingly right again. That's the same department with the same staff moving in and out, although the ward in the middle was where the problem area was. And I know from some reflection with some of the managers in this trust, they realised some of the management decisions that had been made that made the ward problematic. So it's good to have that honest feedback from patients and the relatives. It can be hard for patients and relatives to give feedback, but when it's done in this open and supportive way, the patient and the managers and the professionals become a team to improve the situation. So thank you for sharing, and I hope that as we finish the session this evening, you know, this is just the starter. What will you take away and think about for the next week, the next day, the next month, the next year? That's really what I'm interested in. And always feel free to get in touch with me. You can get my email from the front of the slides. Find me on Instagram, find me on LinkedIn, communicate with me anytime going forward about your thoughts and your experience with patient engagement. It'd be lovely to hear from you. Yeah.
So we had something in the Q&A. Someone anonymous said something, and he's want your advice. And she's saying, I had this challenge a couple of months back where my sister-in-law was diagnosed by end stage of lymphoma upon the discovery. I wasn't in charge of her as a patient, but as a family member, we are hesitant to tell the patient the whole story in order not to lose the courage and the desire to survive. As her life expectancy were less than 10 weeks, my question, do we have the right as a family to decide on behalf on a conscious patients because we assume we know the patient possible reaction? So do they have the right to tell the patient that, or it's part of palliative care that we should protect the feeling of the patient?
Yeah, so that's really interesting for lots of reasons. And I just have to give you a bit of honest background. Some of you may know if you've heard me speak before. So I was told I had a stage 4 diagnosis 11 years ago, and I'm fortunate that I was given that diagnosis, and my situation turned out that I was one of the very small percentage of people who've lived longer than expected, and drugs changed and I could carry on. But I know what it's like personally to be told that. I said to the doctor at the time, actually, what I said, don't tell me stage 4. I'd never wanted to hear stage 4. But he knew that really my words weren't, don't tell me stage 4. My words were, I don't want you to tell me it's stage 4. I don't want to hear those words. But he knew that even though I'd kind of said, don't tell me it's stage 4, I actually wanted to know the truth. So he could have said, okay, I'm not going to tell you that. We're just going to have care and let's see what happens. So he understood, he knew me well. And he said, I would have to tell you it's stage 4. And I never cry when I'm given bad news, but I have to admit, a tear came out because those are words I never wanted to hear, and the percentages were terrible. So nobody wants to hear those words, and I know from personal experience. But for me, if I say it was liberating, awful as it was, it then enabled me to decide, what do I want to do with my life? And because I've had 5 cancer diagnoses, which is a whole other lecture, each time I've been given the truth, and I've been able, they've never known how long I'm going to live. And sometimes I manage 11 months without chemo, and sometimes I'm on it for life. So I've been able to make decisions that even I thought I wouldn't make. So when I was told I was stage 4, I thought, well, do I give up work now? I don't know how long I've got to live. And I would have always thought, yes, I want to give up work. But actually, when it came to it, I didn't. I realized that in my situation, because I was still feeling well, no matter how long I had to live, I wanted to work. But also I knew I wanted to prioritize my family. So I shrunk my world down into like key categories. So family first, my work was really important, my friends were important, my faith was important. I shrunk my world down into what could be manageable if I had a year to live, if I had less than a year to live. So yeah, I don't know if that answers the question, because that's from a personal point of view. But I would say yes, tell the patient, but ask them. So even though the doctor, I said, no, I don't tell me stage 4. He knew I actually did. He knew me well enough to know I wanted the truth. Every doctor I saw after that, I'm like, is it stage 4? Could there be a late stage 3B? So I managed to get a few people to say, well, you could be a late stage 3B, and we now think that's probably what I was, a late 3B rather than a stage 4, and that's why I'm still here 11 years and lots of medication later. But awful as it is to hear those words, if I'd had 10 weeks to live, I would have wanted to know I had 10 weeks to live so I could make those compartments. What are the compartments I want for my life for this last 10 weeks? I wouldn't have had the opportunity to make those decisions if I hadn't been given the facts and the truth, horrendous as it is to hear that information. So I would say sensitively, compassionately, and not just there's your news and off you go, that ongoing support. So I don't know if that helps, but you can always email me and connect with me if you want to discuss that more.
So, Dr. Natalie, it's better not to keep the patient in the dark, because when he will know that like he has like a short time, it will help him making decision and how he wants to live this time. And sometimes there are critical decisions, and it's vary, but mostly I think no one wants to be in the dark when it comes to his health. So we recommend basically telling the patients about his condition. It's a bit a culture in Saudi Arabia. They are overprotective. They tend the family, the husband, the kids, not to tell the patient about their real condition.
I get that.
I'm with you that the patient should know and not kept in the dark. Thank you.
Nobody wants to break bad news. Nobody wants to hurt somebody they love, but we can share the information compassionately and supportively. It's not easy. Thank you for the question. So we'll move on. I think we've kind of gone on to that one. We'll move on. So the case study. So the case study, outstanding care, patient supported in this emergency situation. The patient's well-being physiologically was stabilized in terms of the hemorrhage, and the patient was sent to the ward, which was maybe, I think, 5 meters away, very near, 10 meters away. So it's the same department. And these are some questions that the patients and the mother wrote in the feedback. How can the nurses and the doctors on this ward plan the patient's care with and for them if they never ask the patient a question? How do the nurses and doctors on this ward think that patients can safely manage their condition on discharge if they are given no information or advice? And in the report, the patient's mother and the daughter describe what they felt was minimal care, what it looked and feel like. So they've gone from outstanding to now what they're describing as minimal care. So the mother writes, my daughter's admission to the ward, now not the emergency admission, consisted of checking her name, her date of birth, and provision of a name band, nothing more. There was no further admission questions at the beginning or throughout the patient's stay. There was no introduction by the staff as to their name or their role during the patient's stay. And that the stay, I think, was maybe 5 days, and then the patient went home and came back. No assessment questions to enable patient-centered care and patient safety. No sharing of information to enable shared decision-making, patient safety and patient autonomy. So not great, in fact, minimal. And it's the opposite of what we're saying in this lecture. How can healthcare professionals enable patients to be proactive partners in the care. There was no foundation for the patient being a proactive decision maker with their team. There was no indication of care interventions and when these may take place. And this is now no longer the emergency situation. This is like the patient's there for 5 to 6 days, no checking how the patient was feeling physically, psychologically, or emotionally, no opportunity for the patient to ask questions, no opportunity for the patient to make autonomous decisions about her care, no shared decision making. It's the opposite of what we've just heard in the emergency situation, isn't it? And this is contemporary. This is 2022 in the UK, in one department that's getting it so right and now getting it so wrong. The patient was discharged. So the report goes on for 6 pages and we don't have time to go through it all, but the patient returned to the ward because she didn't understand her condition. She was feeling more frail. She didn't have enough medication. She had a life-threatening hemorrhage risk that she didn't have enough medication to manage that life-threatening hemorrhage. And so the patient and the mother turned back up at the ward unannounced because they couldn't get anybody on the phone and nobody would return a call. So they literally just presented back at the hospital, and they were met by a senior staff nurse and the head of the department by chance in a corridor in an office. They just happened to walked into an office and said, "We need help, this is the situation." And the senior staff nurse and the head of department responded to this unusual request of a patient and the relative literally turning back up on the ward asking for help. And in a short amount of time in the report, it describes how the senior nurse and the head of department turned this situation round of desperation, where the patient hasn't been involved in decisions about their care, discharged, no information, not enough medication, no understanding, haven't been involved in decisions. But there's going to get better. My story with you tonight, because this nurse and this doctor transformed the patient and her family's experience from being ignored and dismissed to an experience of being safely and professionally cared for. That's just, well, it says it's transformational, isn't it? It's transformational in that moment, and it's transformational for that patient in their healthcare journey. And it's transformational in how that patient in future care experiences, what that patient's expectations are. Do you expect me as a patient to be proactively involved? Or should my expectation be, I'll be ignored, I'll be dismissed, and your thoughts and decisions about my life and my treatment are the ones that will be given priority. So from the literature that we looked at briefly on apprising, giving information, valuing the patient's experience, preferences, mediating with the patient, family and health professionals, championing for social justice to make sure everybody's entitled to this, and safeguarding where care is poor and protecting patients when we know that there's poor care, that we address that, we don't allow it to be covered up, is all part of the care that I'm arguing for, and I'm sure I'm speaking to people who would have very, very similar thoughts. So we're getting to the end of our time, because I know we want to allow time for questions. So a few more slides to go, and then I'll hand over to you for questions. So I'd just like for you to think about, in your organisation, how do you know if patients are experiencing being proactive partners in care? In this situation, the patient and the mother wrote a 6-page complaint report, submitted it, followed by another formal complaint just written by the daughter. In the UK, we have something called the Friends and Family Test that you can look up online, and in different NHS National Health Service hospitals, there are small leaflets that patients can pick up and write their evaluation of the care in the ward and pop it in a little post box. We can go online as patients and give feedback. We have our Care Quality Commission where we can give feedback, and every hospital has a PALS department, patient advice and liaison service. So we don't have time to discuss this in great depth, but just I'd put on as one of the objectives to think about, how do you evaluate your patient's experience? And this is just a couple of the ways in the UK. So when complaints come in, like this one that we're looking at, the first route is often to the PALS team, the Patient Advice and Liaison Service. Sometimes these are escalated up hospital departments, maybe to the hospital solicitor, to the board, to heads of department, but it may often be the PALS team that we start with. So to conclude the patient study, so the patient has gone back to the ward and said, I'm frail, I'm only in my late 20s and I'm frail because I'm so anemic, I've lost so much blood, I'm at risk of this life-threatening hemorrhage, I don't have enough medication. It gets transformed, thankfully. The patient was listened to, the patient was a proactive partner in the decisions about the care that followed from that moment in time. And then the patient's follow-up was at a different organisation, and the feedback from that department or to the department is the nurses and doctors involved in her assessment, care during a surgical procedure, and in her preparation for discharge were outstanding. The feedback was that the nurses, doctors and care assistants ensured support for the patient's autonomy and acted as our advocate throughout this procedure and discharge, and the care was seen as fulfilling codes of conduct for professionals and the organisation's vision and mission. And the patient was proactively involved from the moment she arrived through each stage to the moment that she was discharged and returned for ongoing care. So we've had a whistle-stop tour. So hopefully I've given you things to think about. You may not have agreed with everything I said. You may not have agreed with anything I said. You may have agreed with some of the things that I've said, and do get in touch with me to share your feedback, because it's about two-way learning, isn't it? I need to learn from you as well, and I'm just sharing things that I've read, things that I become aware of, and I'm really keen to learn back from you. So please get back in touch with me. My email is on the front of the slides, and I'd love to hear from you. And just to summarize what we've done in this very brief consideration of something that we could spend such a long time reflecting on, we've critically considered how the healthcare that we provide, that's you and me in my role, can include patients as proactive partners. We've critically explored different strategies to empower patients, and think about how you can do that in future with your colleagues and patients. We've reflected briefly and critically on the benefit of patients being proactive partners in care decisions. We've looked at some of the negative outcomes when care isn't patient-centred and patients aren't empowered and aren't proactive partners in decision making. And I'd like you to go on to think about all of these with your colleagues and with your patients, including how patient experience can be evaluated in terms of their proactive partnership with us as healthcare professionals. And there are some references there. So that's the end of my...
At the end, we have a lot of interesting questions. Thank you, Dr. Natalie, for this interesting topic. Actually, people are active and they have really interesting questions. First question, I can relate to that question a lot. What about a proactive patient with different languages that healthcare officials use of communication, especially during the nursing handover? For example, in Saudi Arabia context, patient mostly speaks Arabic, while healthcare workers are using English during the handover. I think they mean the bid handover, because the purpose of bed endorsement is to let the patient know exactly what's going on with his condition, while most of the patients here, they speak Arabic, but because the diversity in Saudi Arabia, the multilingual and the official language in hospital is English. So it loses the purpose of bed handover. Because it's intended for the patients, but most of the patients don't understand the English language.
I had an interesting experience at an education conference in Saudi Arabia, maybe 6 or 7 weeks ago, and I went to a session, and it was an international conference, and I hoped there might be some English translation, and there wasn't. And you know what? I sat through 2 of them, even though I didn't understand a word, because I thought, how often do you get the opportunity to not understand what's being said? And I just wanted to really learn from that. So I did, like I say, I didn't just sit through one, I then sat through another. Could I pick up the odd word that I knew? Could I pick up a picture and then the body language that was being used? And yeah, it's like being muffled almost. It's like being wrapped in cotton wool that you're trying to understand, and you're just picking out maybe an odd word that you can hear. And I know from being at the Saudi Patient Safety Conference in 2019, the language barrier was discussed in a session that I attended there. So if we're saying it's the patient's right, somebody's duty, isn't it, to translate and quickly translate, because it's about the time to summarize and translate to the patient. This is what's being said. What do you think? That would be my suggestion, that if we're saying somebody has a right to make proactive decisions, and it's a language they don't understand, who can translate and give a summary and say, this is what we're discussing, what do you think? It's not easy, and I know in Saudi Arabia you have that English language as your professional language. It's great for the professionals, but we're saying it's the patient's right to be involved in decisions about their life. So how can they be involved if nobody's translating it for them? So my goal is to improve my Arabic language. At the moment, I've been improving my French because I've just been to France. But again, it's our duty, isn't it? So yeah, but I'm also working with Kyrgyzstan, so I'm trying to improve my knowledge on Kyrgyz and Russian. And I'm not a natural linguist, but we can all make an effort to learn a language that we think we're going to be meeting some people that's their first language. So I've got lots of books and CDs and in the car, and so whichever country I'm going to link with, I grab that and just do the best I can.
We have another, thank you, Dr. Natalie. So we have another question from Ghina Al-Arab. She's asking how we can improve patients and family health literacy so they can be engaged, keeping in mind the medical aspect as something hard and not easy to understand.
That's interesting again. And I'll just reflect on an experience I had a few months ago. I was away for the weekend, but COVID was around quite a lot. And my husband said, when I got home, he said, oh, the lady up the lane came down. I thought, oh, that's interesting. The lady up the lane has never been to my house. I wonder what she wanted. So next time I was walking up the lane, I knocked on and said to the lady, what, you knocked at my house. Was there something I could help? She said, I heard you were a nurse and my daughter is having IVF. And because of COVID, I, the mother, have to give my daughter an injection. I have no idea how to give an injection, and I've been told to watch a video on YouTube on how to give an injection. So that was all well and good, but as healthcare professionals, if we're involved in an activity and we have the training, somebody then assesses, are we safe and competent that first time? And this mother who was in her 70s, who'd never given anything or anybody an injection, had to rely on a video. And I think what she was missing was somebody to watch her that first time to say, that you're doing it right. And there was a piece missing. She was given the video, so she had improved her health literacy. I think it was better to give them a video than something to read, but it's people's preference, isn't it? So she knew what she needed to do, but she just needed that assurance that her giving her daughter the injection, she was doing it the right way. So think of creative ways of sharing information, but we need to give that follow-up stage that we would always have as a professional if we're learning something new, that somebody who knows what they're doing checks us. So yeah, videos, whatever the preference is for the patient to improve their health literacy, little and often, I would imagine, but who can the patient come back to check that they've got the right understanding? We expect that as professionals. Why don't we always make sure that patients and their families who are improving their knowledge of health, that they've got somebody to go back to check, have I learned this right? Am I going to be doing this right? But it was COVID, so everything was more difficult in COVID.
Thank you, Dr. Natalie. This is interesting. So having different methodology of learning and teaching can help. We have another question from Ms. Makia Majrashi. She's asking, do you have any advice of including patient stories within healthcare strategies to improve the patient's engagement?
So I do some work with an Australian dementia care company that work internationally, and we've just done a big evaluation on people's experience of living with dementia, and we put patient stories all the way through that. We had a really strong commitment to patient stories throughout, and that was my job in the evaluation, was to capture and tell the patient stories authentically. And if I say I'm proud of it, that sounds a bit like big-headed, like, hey, look at me, what a good job I did. But I don't mean that. I mean the work we did together, that I know I was fortunate to have the time and the resources to capture the patient stories authentically so that they could be told in the document, in the report that patients and their families will read. So I think it's definitely to be celebrated when we get patient stories and tell them authentically. So yeah, I love my work, and I love patient engagement, and I love patient stories. So yeah, and it's okay. It's no good if I just think it's great, but when the patients say that was so powerful when I read that patient story, or when I read my own, or when patients say I read my own story in that document, or a mother says I read my child's story, and then other people say this, you know, I learned from that story. It is really, really powerful, but it takes a bit of time, but it's always worth it.
So we have another question. It came from the messages. If we want to include, from Mr. Ali, if we want to include the patients and families in our team, do we have the right to include them in our sample with medical staff to measure something in the research area?
So again, from my experience of research, I always look at involving patients, residents, families, whatever the combination needs to be. I would always make that effort to involve, whether it's just patients or patients and their families, or patients and friends. It depends what the situation is. Yeah, I would always recommend taking that time, and that's something in my research, I always make sure I put that first and center, to not at the end. Plan it in from the beginning and have your patients involved in the beginning. And there's a hospital here in Greater Manchester, an outstanding cancer hospital, and I know they have a very strong commitment to patient involvement and engagement from the beginning in studies. So patient representatives would be invited to team meetings right from the beginning and would be made welcome. And they may need that health literacy to be able to contribute. It's no good inviting patients and their families along if they feel inadequate and they don't have the language and so don't speak. We need to empower our patient representatives who are involved in our projects. And it takes longer, but it's always well worth it.
So I think Mr. Ali, Dr. Natalie is encouraging you, definitely can do. Include the patients and their families in your research, as we are asking if we have the right, as long as you have all the legal document, IRB, consent signed, you are on the safe side, no worries about it. So when we can take only one last question, as we are reminding, we have 1 minute left. This is a bit harsh, Makia. Doctors always dominate about taking decision for their patients. She's asking, how did it change in how did it change in UK? I'm not sure if it changed. I think it's a global issue. It's not only in Saudi.
Yeah, and that's why I tried to make clear at the beginning, I'm certainly not saying, hey, in England we've got it all right. I'm certainly not saying that, and that's why the example I give is mixed. And I've been reflecting on this because I was involved with something at the Princess Noor University earlier this week, and there was a similar point that we discussed. I think the question we need to ask ourselves is, who are we serving? So if I'm a nurse, am I serving the patient? If I'm a doctor, who am I serving? Am I serving the patient? And I would hope the answer is that yes, as the doctor, as the pharmacist, the radiographer, the physiotherapist, the psychologist, the nurse, the healthcare assistant, we're serving the patient. And you can't be serving two people. You can't, if we're serving the patient, we're serving them together as an interprofessional team. And so it's that partnership. So it shouldn't over the patient. Well, I would say whether it's
for him.
If it's professional, it's not my earnings. We're there to serve the patient. We're there to serve the patient. So that's just a question to ask ourselves. And if we feel somebody is expecting that we'll be deferential to them, we're serving the patient, and we're serving the patient proactively to all of us. But who are we serving?
The patient, and then all of us, even from the medical professional, even to the security, even to the housekeeper, I think.
Yeah, and I know in this case study, if you look at the professionals who got it right, and if you'd asked the patient, I think they would have said the doctor, the nurse, the healthcare assistant. I know that I'm the centre of this situation, and I feel that the head of department, the senior nurse who are described in that, I feel if you'd asked them, they would have said, we're here to serve the patient. And maybe the ones who got it wrong don't see that we're serving the patient. I think maybe that's where the problem is, where people forget the serving the patient.
So thank you very much, Dr. Natalie. It's very interesting. I feel like I don't want to close the session. We have more questions, but the timing is a bit tight.
Yeah.
So on behalf of the Saudi Patient Safety Center, we would like to thank you, Dr. Natalie, and the audience for their active participations and their nice questions. As part of the Saudi Patient Safety Center's effort to provide you with timely topics and interesting speakers, we would like to appreciate if there is to fill out an evaluation form, a survey, provided at the end of this session. Thank you all for joining us today, and we are looking forward to see you again. Thank you again.
Thank you, everybody.